Thank you all for joining. Can we let people use their video? Okay, it's coming on. Thank you. We can get started. I see only Jacqueline. Jacqueline, can you see the screen? Okay, I just want to make sure. Good afternoon, everyone. Thank you for joining. I'm Dr. Sailaja Musunuri. I'm the Chief of Psychiatry. This is a very important topic for us who are working with individuals with autism and intellectual disabilities. And actually, I'll be doing the intro and going over some of the details with what does intellectual disability and autism individuals present with as far as the psychiatric and behavioral struggles. And Tiffany Adams, one of our psychiatric nurse practitioners, later on will be discussing the clinical case examples and we'll be going into more details about real life situations here at Woods. Without further ado, this is maybe basic for some of our clinical teams, but I wanted to go over IDD as it has changed the landscape a little bit in the past few years, where we were a decade ago to now. There is a lot of emphasis on how we are diagnosing individuals with intellectual disability and what the focus is. That's changed quite a bit. In DSM-4, there was a lot of focus on, that was a decade ago, about the scores. There was a differentiation with mild, moderate, severe, profound, and we were paying a lot of attention to what did they score, IQ scores. When DSM-5 came into the picture, there was a lot of emphasis on what is their functioning level. It's not just the score, but also looking at their adaptive functioning. And one of the other criteria is the onset of deficits have to be during their developmental period. And the intellectual developmental disorder is one of the kind of like we call it intellectual disability, and that's where all the medical journals and clinical practice and all in DSM-5 we use the intellectual disability. Developmental disorder came into picture in ICD-11 with some coding. As we have some medical folks, I included that as well. And what are the adaptive functioning skills that we are really looking at and how we are differentiating mild, moderate, severe? We are looking at areas of difficulty in conceptual skills, adaptive skills, and social skills. When you look at the conceptual skills, they're mainly telling the time, reading, writing, language, and really the practical skills are more about their ADLs, bathing, toileting, self-care, and how are they able to use the telephone, paying bills, and things like that. Social skills are more about how they are interacting with others. Can they build interpersonal relationships, and are they able to understand the risks in their environment? What are the comorbid neurodevelopmental disorders, which the main one is the autism? There is a high comorbidity for autism with IDD, which is at or below 50%. But not every individual with autism has intellectual disability. We cannot assume. That's why we do recommend for psychological testing and Vineland Adaptive, as well as the IQ testing to figure out where they fall. And autism spectrum disorder, we are mostly familiar with it, is presenting with characteristics of deficits in social communication, interactions, and restrictive and repetitive patterns of behaviors. And it should cause significant impairment in several areas of functioning. And other comorbid neurodevelopmental disorders, one of the biggest is the attention deficit hyperactivity disorder, which can co-occur with IDD. And also there are other neurodevelopmental disorders which involves communication, motor, and the other specific learning disorders. And the coming to the topic for discussion is the comorbid psychiatric conditions with IDD. There is a high prevalence of psychiatric conditions in IDD, and than the general population, they're almost like 3 to 4 times higher. And common psychiatric conditions that can occur and we see are major depressive disorder, bipolar disorder, anxiety, impulse control disorder, and psychotic disorders or schizophrenia can occur. There is always a difficulty with diagnosing schizophrenia because it is in the general population. It's about 1%, and if we think about it, it's almost about the same. And other neurocognitive disorders and stereotypic movement disorders can also co-occur. And the psychiatric conditions, and they can manifest differently because of the lack of their processing ability, and also express and they are not able to express the symptoms. We need to have a high level of suspicion if there is a change in the behavior. And there is in the diagnostic manual intellectual disability, they discuss how the psychiatric conditions can be adapted, and to have that level of suspicion when we are working with people with IDD. And why is it so important to diagnose a psychiatric condition in individuals presenting with IDD? Because early recognition and access is really important. And they are also very heterogeneous, so there is no cookie cutter approach that one plan does not work, and the treatment plan has to be individualized and person and family centered. And a lot of times, because of the cognitive and communicative impairments, we need to gather information from the caregivers and others who are working with the individual, as they cannot express themselves. And also, a lot of times when we are evaluating or making recommendations, it is really important at the beginning to establish guardianship, who can make decisions for the individual. Especially when it comes to the medication management, we need to make sure that there is a legal guardian who is making all the medical decisions be available for our appointments and evaluations. And the other difficulty in when there are psychiatric conditions comorbid with IDD is the assessing the impact of trauma. They are most likely to be victimized. There is increased incidence of physical, sexual abuse and neglect. And also because of the difficulty with processing information, a lot of times they tend to develop the PTSD symptoms early on. So the acute stress reaction can present as a behavioral escalation. So it's really important to integrate the trauma-informed care into the treatment plan and the treatment that we provide. And we also need to assess what is the perception of the individual to the alleged traumatic event, because the emotional response can be totally different. They can present with externalizing or internalizing behaviors. The externalizing behaviors can be misunderstood as behavioral or oppositional, or more of an impulsive outburst versus something they are having difficulty with processing internally can result in an externalizing behavior. So the trauma-informed care and supports and the staff training and the parent training are a key in addressing those behavioral difficulties. And coming to the other category, which is the comorbid medical conditions, which can occur with IDD. Seizure disorders are very common, and they have a high comorbidity of close to 50% again. Another thing that we always need to remember is the allergies. Allergies to environmental as well as food and medication allergies. And seasonal allergies are a big one. So we need to make sure that our children and adults are actively receiving the treatment for allergies during the season. And inner ear infections, any kind of GI issues, sleep issues, and any vision or hearing impairments are comorbid as well. Oral health problems are a major issue. I'll get to that part about the follow-up and preventative appointments. Also, constipation. A lot of psychotropic medications can cause constipation as a side effect. And also, they have irregular bowel pattern. In addition, if we are using medications that can cause constipation, it can be double and triple fold, and that can cause significant discomfort and can result in an escalation in behaviors. And individuals with IDD and neurodevelopmental disorders, we all know there is a possibility of early onset of dementia in certain genetic syndromes. And why is it important that we need to keep these psychiatric and medical comorbidities in our checklist is that there are difficulties with diagnosing these conditions in individuals with the IDD. And those we call them as the potential roadblocks to diagnosis. And it is mainly because of the lack of cooperation with the medical or psychiatric evaluation, which can make things really difficult because we are not able to, when it comes to a medical examination, they may not be able to thoroughly examine the individual. And psychiatric evaluation is the same thing. They could be engaging in behaviors in our office setting, and we may not be able to see the real picture. And unfamiliarity with the office environment, and it could be overstimulating, and we are bringing them into the small office that can result in both an increase in anxiety and behavioral challenges. And also, there is an increased difficulty with the transportation. It is a change in their schedule. They may not be willing to come out of the house and get in the car, and the caregiver may have other difficulties with transporting them. A lot of times, they may be coming late for our appointments, and they may miss the appointment as a whole. That happens quite a bit. And you all know from the campus to the medical center, there are significant delays with getting our clients to be seen by the medical doctor. So those things can happen as well. And this is a big one. Some of our individuals prior to coming to us, they may not have had a dental examination done because it is too troublesome, and they may not cooperate. And also, they may not be trained providers or dentists in the area who can really handle individuals with IDD and autism. And that lack of preventative care resulting in dental as well as medical complications. And also because they are not able to express, even if they have pain or discomfort, or if they are feeling sad or anxious or having difficulty with sleeping at night, all this information has to be coming from another source than the client. So a lot of times for the provider, gathering information can be a challenge. You need to have the informant whom we can rely on to gather that information. And it has to be the caregiver who is working with the individual day to day, every day. And it could be the parent or family, from if they are coming as an outpatient, and from the residential setting, that's why we ask who is the staff working with the individual. And a lot of times we rely on the treatment team to gather that information and send it for the appointment with the physician or with the psychiatry folks. And when we look at somebody who is having a behavioral escalation, it could be aggression, or just having a tantrum with everything put together, which can be lasting, which could be an ongoing issue. A lot of times we look at a list of things prior to coming to the medication part. There could be changes in the environment, or there could be a change in the staffing, and there is a schedule change. All of a sudden, during winter, we may have a delay, or maybe there is a school holiday during weekday that they were not able to process that part. Oh, all of a sudden, why are we not going to school? We are at the residence, and next day we are going to school. That schedule change can throw them off. And overstimulation in a setting, in a classroom setting, for example, a new student who could be making a lot of noises and disruptive can change the whole thing for an identified client. They could be getting upset and having behavioral difficulties. Sleep makes a big difference. If they cannot sleep at night, they are awake and engaging in behaviors, and next day they are tired and they are on multiple psychotropic medications. They could be making them tired during the day. So, gathering the sleep data and information is really important. And also medication side effects. They are on multiple medications and they could be on other medical medications. The drug-drug interactions could be causing more agitation. Trauma is something that I mentioned previously, and they could be having a medical issue. They may have a migraine headache, or maybe they have some kind of a GI discomfort, constipation, any kind of infection, pain somewhere, dental issues, or seasonal allergies. They all can cause agitation or behavioral escalation. And how do we manage the behavioral escalation with this population? And we always look at this is the most important thing before we get to anything is the non-pharmacological approaches. How do we manage these individuals who are presenting with behavioral and psychiatric challenges? First and foremost, check for if there is anything going on medically. Are they having pain somewhere? I think this is one of the things we always say is like teach them when we are working on improving their functional communication skills is to show are the icon for hurt, pain, and are they hungry? Is it happening during meal times? There is one another when we think about the medical part. Sometimes they could be more disruptive during meal times. It could be a lot of things can happen during meal times. It could be overstimulation. This is something they cannot handle. And a lot of times they have sensory needs. And also it could be that they may be having a GI issue, maybe a reflux that can cause stomach upset or burn in their stomach, and they avoid eating meals. So there are things that we need to look at. And also, apart from addressing the physical needs, we need to look at what their schedule is looking like. If they are having behavior certain time of the day, maybe creating a schedule and utilizing some visual boards and social stories. This is how we are going to handle the situation and work with the clinical team to come up with reinforcement strategies. And also, if it's a high demand situation, they're trying to engage in behaviors to escape from the demand. It's almost like looking at every before why this is happening and what's going on during the incident, and then what do we do next? The functional behavior assessment and coming up with behavioral interventions to address the behavior. And if it is overstimulation, try to identify a calming area. And sleep is really, really important, developing a sleep hygiene. So when there is a behavioral escalation, always look at and check all the boxes that can be contributing to an escalation in behavior prior to coming to the next slide, which is the pharmacological approaches. Even for pharmacological approaches, the first thing we do is look at the meds. Medication reconciliation is really, really important. In Edwards, we try to do a lot of times is the integrated care. I'm not trying to say that we are the best EHR or there is med reconciliation is happening hopefully in near future, but we need to compare the med list from the medical providers and other specialists that are involved in the client care along with the behavioral medications and check the PDMP, make sure that there are no drug-drug interactions and the client is not exhibiting with any side effects. Another important thing is correlate the behavior with if you are starting a new medication. The psychiatry team may have started something recently and there is an escalation. That's something we need to know. So that's the data-driven approach that we need to mark that start date and look at the behaviors and go back to the team to discuss if the medication is causing agitation and increase in behaviors. And also, it's really important to get detailed history of what was tried in the past so that we are not making these trials and errors all over again. And if it is an outpatient who is coming to our clinic, parents may not be aware that some of the times the PRN use are certain benzodiazepines that they have been using. For 2 days they use it, and then the third day they don't use it, or fourth day they start again. There could be withdrawal going on, which can cause some level of agitation. So getting a detailed medication history is really important to address the behavioral escalation. And then finally comes the pharmacological approach. What do? We checked all the boxes, and there is clearly something going on internally. It could be a psychiatric comorbidity that we need to address with the psychotropic medication. And that's the last resort for us, that thinking about the medication option in individuals with IDD and autism. A lot of times, if someone is presenting with a behavioral escalation, there is a lot of research in individuals with autism as well as with dementia. There is a low dose of atypical antipsychotic can be used to address the agitation and mood irritability. There are two FDA-approved medications. One is risperidone, and the other one is aripiprazole, which are Risperdal and Abilify. There are off-label uses for the other atypical antipsychotic medications. We need to keep in mind that they can cause sometimes sedation, hypotension, low blood pressure, can cause, dizziness. All those things can happen. The biggie is the metabolic syndrome side effects, which is kind of like a weight gain and glucose and lipid abnormalities. But the thing is, it increases the appetite. So that's one of the concerns that, and we start putting restrictions on, or maybe put them on a diet and things like that. That causes another power struggle. So the behaviors tend to escalate. So we try to avoid causing, we don't want to keep on adding medications. So if there are side effects, we need to go back to the medication regime and address if there is anything going on medically that can be exacerbating the original behavioral escalation. And if they tend to be more impulsive, we use alpha agonists, which are clonidine and guanfacine. The one thing that we need to monitor is the blood pressure. And if they are really presenting with attention deficit hyperactivity symptoms, hyperactivity, problems paying attention, or impulsive behaviors, we use the stimulants or atomoxetine, which is the Strattera. My team knows that I'm not a big fan of antidepressants for a good reason. If they tend to be anxious, or if they appear to be somewhat depressed, or if they're presenting with PTSD symptoms, definitely antidepressants are the choice. One of the things we need to remember is the individuals with autism and intellectual disabilities are extremely sensitive to the doses of SSRIs that we use in adults. So we are starting a baby dose, especially when it's only necessary. The increase in activation can make things worse. We are using like a really, like if you think about fluoxetine, we are using 2 milligrams as a start dose, and we need to start low and really go slow, titrate really, really low. I know we do have some parents who call us, constantly that it's been a week, you did not increase the medicine. It's such a low dose. It's about parent education and training, stand on your ground and then kind of explain it to them that it can make things worse. The watch for suicidal behavior is because of the activation in an individual who is really presenting with significant depression and have self-harming thoughts, and then you add a medication that can activate them, can result in an increase in self-injurious behaviors and suicidal behaviors. The one of the things that we need to remember a lot of times, our psych NPs and myself, who we watch for any kind of activation or restlessness because of the antipsychotics or antidepressants. Low dose of antipsychotic can cause what we call akathisia. And our individuals are already somewhat hyper because they have self-stim behaviors, they're pacing, they're constantly on the go, and you add a side effect of akathisia to that already hyperactive individual, they're out of their skin. They cannot sit still. And if there is anything on the way, they can become much more agitated. So we need to carefully monitor once we start the medication. That's why the whole mantra is about start low and titrate slow. One of the other class of medications which we are not big fans of is the benzodiazepines. It can help with anxiety and also in situations where we really need to address, for example, for an appointment or for a home visit or during transport. Those are the times that we use benzodiazepines at low doses. The worrisome thing is it can make them disinhibited and can result in increase in agitation. And also they can develop tolerance. The body that can get adjusted to the dose real quick, and then that 1 milligram of lorazepam may not do the trick, and then we keep on going. It doesn't do anything after some time. And Benadryl or diphenhydramine is another one that can cause disinhibition. And in individuals who already have a seizure, we need to be extremely careful because it can lower the seizure threshold real quick and they may have a seizure at night. So when we are using this medication for sleep or if they're having trouble, we need to be careful. One of the other medications that I have not included here, which we use quite widely, is the another antihistamine, Vistaril, hydroxyzine, that we use quite a bit. It does also go through the serotonin receptor, so double whammy. And the other thing, we should pour it in the water, is the melatonin. It's the sleep medication, doesn't have many side effects. It doesn't go through anything. So if somebody is having a sleep difficulty, that would be our first one. And then that improving the sleep may improve the behavior next day. I'm going to hand over to Tiffany to give some case examples, and then I'll come back for the integrated care. Tiffany, I can move the slides. It's up to you.
Yeah, that's okay. If you want to keep moving
Yeah,
on, that
sure.
would be probably easier. Thanks, Dr. M. So I'm going to go into some of the case studies to just further demonstrate the information Dr. Musunori went over. Our first is Paul. He's an 18-year-old young man. He is nonverbal, and he carries diagnoses of autism, IDD, OCD, and self-injurious behavior. So he is brought to the psychiatrist by his mother, direct care provider, because he's had increased head banging. Following a big change, he moved out of his mother's home where he was for 18 years into a group home. His mother's health was impacting her ability to care for him. And since he's moved, he's been very dysregulated. They've observed him pacing, having these temper tantrums that can last a half an hour. And the direct care provider was able to identify some interventions that have been helpful, like playing his favorite music, giving him his weighted blanket, and historically, he had a head banging as a symptom that he presented with that was displayed typically with past demand or when he was denied access, and that would occur occasionally. However, over the past 2 weeks since his move, his head banging increased significantly without those typical antecedents, sustaining a laceration to his head. And of course, his mother became very upset. And that's something I know we've all dealt with, having a parent, in tears telling us how disheartening it is to see their child in that much discomfort and feeling like they were somewhat helpless and didn't really know what to do next. And that's typically what brings them to our door. So at the psychiatrist's office, the psychiatrist, of course, explained to mom that the increase in head banging likely is related to his recent move. It was a big change in his life. And he ordered some clonidine to help with the impulsivity, as well as a soft helmet to help to protect against further injury. Brought him back in 2 weeks to see how those interventions were working. And unfortunately, at that time, the frequency of the head banging did not decrease. However, he hadn't sustained any further injuries due to that helmet. They also observed that he had been rubbing his eyes very often. And so the psychiatrist decided to refer him, since the interventions weren't really successful, to the primary care provider to help rule out any possible medical causes, particularly with the eye rubbing being observed. At the primary care office, they felt that the eye rubbing was related to itchy eyes, so they prescribed an allergy medication, Claritin. However, it did not help. And then he began refusing his food and having some vomiting episodes. And one thing that really stands out to me in this case study is the direct service provider, that direct care staff being able to observe so many pieces that they're able to report to the physicians, things like refusing his food and what interventions have been helpful. And they also saw that when they were vacuuming the house, he would become agitated and sometimes even aggressive towards the person vacuuming, which is, I think, a really big piece of information that they were able to bring to the provider to help them make their decisions. Also, another piece is that he was staying in his room with the lights off more often. And those are two symptoms that helped the primary care provider diagnose Paul with migraine headaches and start him on Excedrin migraine. And fortunately, after that treatment was initiated, his behavior returned back to his baseline. So you can see a lot of these symptoms, Paul being unable to explain what he was feeling, were displayed in another way. And it's only through really those direct care staff and the people involved and the physicians seeing those different presentations and kind of thinking through them to try and understand what Paul was going through that led to that display. So we have the headache that was demonstrated by the increased head banging, the vision changes, and possibly an aura he could have been experiencing, some different lights that caused him to rub his eyes to try to clear his vision, photophobia, that sensitivity to light where he's staying in his dark room, and that heightened sensitivity to sound and the agitation with the vacuum cleaner, and that poor appetite, which was displayed as refusing his food and vomiting. So really great success story with that one. And then we'll discuss another case study. We have AT, who's a 33-year-old man. He has a diagnosis of brain injury, hydrocephalus. He does have a VP shunt, Parkinsonianism, and dementia. He's presented with a sudden change in behaviors and mood, and also sleep issues and urinating on the floor, which is unusual for him. So the psychiatrist was consulted. And what the psychiatrist is going to do in this situation is carefully review the medical records, including the neurology and urology consults. Are there, new changes in the treatment plans? Are there anything that was found at those recent visits that could be contributing? As well as getting this timeline of behavioral escalation through the staff interviews, the sleep logs, all the incident reports, the discussion with the primary care provider and the neuropsych team, trying to really gather all of the available information so that they can try to put it all together and figure out what's going on with this young man. Number one thing we want to do, we're having urinating on the floor, rule out a UTI. UTI we know can contribute to a lot of symptoms behaviorally in an individual. So that's a really big one to help rule out. And it's a pretty simple one, right? We just are going to get the urinalysis and see what's going on. Another thing would be a phone call with the neurologist to talk about, have there been medication changes? Memantine has been started. So is that contributing possibly to any of these symptoms that we're seeing? And also to understand the progress of this young man's dementia. Are these changes something that could be related to that diagnosis, and something that we can address in that area? I know we had, this made me think of a couple other things, and I think some of you have worked with me on some people. I know that I have worked with a young man also with fecal incontinence who came to us, and this was something that we worked through, and he was really successful and did a great job. And when that behavior started to show up again, we were like, this is strange. Is there, is something going on here? And actually, we were able to discover that he was struggling with constipation, and that is what led to that resurfacing again. So that was really interesting. And another situation, and these are just recent ones I've been dealing with this month, is a young lady who presented with irritability that we really just could not get under control with environmental interventions, psychiatric interventions, and ended up looking at her thyroid to determine if something was going on there. And she's very difficult to get that blood work done, but we finally got it and found that she does have hypothyroidism and has started on a medication. And she's a nonverbal young lady. So, all we really saw was the irritability, but I have to think, was she experiencing, the sensitivity to cold or some of these other symptoms that we may see? So it's interesting. Sometimes you only see that one thing, and that may be what moves you to discover what the issue is. So that's it. I'll hand it back to Dr. Musunori to finish up.
Thank you, Tiff.
Mhm.
Those recent examples, what precipitated us to think about doing this topic for this presentation. Thank you for that, Tiff. So in summary, when we are looking at a behavioral escalation or agitation in an individual with autism and intellectual disabilities, we always work as the integrated treatment team, and we develop one treatment plan. So a lot of times, what we come up in our medication reviews as well is to look at really addressing the behavior from the data perspective. When we are making changes or starting medications, it's really important to delve into what is the data looking like. So, and also we can avoid medication changes if we are looking at data, when did it start? And looking at the function of the behavior and utilizing behavioral interventions first before the medication changes, and minimize medications when possible. And again, minimize polypharmacy. This is the good one. We do have some individuals who come in on the recent admits of the year ago, 6, 7 different medications, and we don't know which one started first, but you can imagine maybe they started one and went up to the high doses that caused some side effects. My good old example, one of Jennifer Capoto's client who was on 6 different medications. One of the antidepressants was Paxil. You can understand Paxil at high doses causes akathisia and the increase in agitation. And then to address the restlessness, they think it's ADHD. They add a stimulant, and then they add an alpha agonist, clonidine or guanfacine, and then that causes some mood irritability. And then they go to atypical antipsychotic. Our atypical antipsychotic was already there as a start, and then the stimulant and the antidepressant could be making them having sleep issues. They add a couple of sleep medications, and then they may be thinking that, oh, he's on an antipsychotic, but his mood is still up and down. They add a mood stabilizer. They end up on Depakote and lithium. So this is the scenario that goes. It's easy to end up on 6, 7 medications, and it's our job to figure out what's going on. And gradually, a lot of times, we start tapering one by one. And it is important to coordinate with primary care because the medications can interact with other medical medications, and also medical conditions can exacerbate the condition. So it's always really important to rule out medical etiology first, which can be contributing to the increase in behavior prior to thinking about starting a new psychotropic medication. And the high level of integration between the providers, the primary care, the specialists, and the behavioral health team, residential team, and the nursing is important to address any kind of behavioral complexity in individuals with autism and intellectual disabilities. And there should be exchange of information, and that's where the integrated services comes into picture to share the electronic health record, which we have. And also, if there are other services involved, not so much with our woods, but with the outpatient setting, it's important to coordinate and really gather information from the in-home services team and other providers who are involved, and if they are going to the outside school, gather information from the educational system, teachers, and other caregivers to really find out what's going on. And one treatment plan, comprehensive treatment plan that addresses all the issues is really the key. And what are the benefits of the integrated care model is that enhanced access to services, and we can easily make a referral if they need one to the outside services, and it improves the quality of care. Of course, it cuts down the healthcare cost because we are eliminating a lot of unnecessary tests and unnecessary visits to the higher levels of emergency room and the needing for the higher levels of care. That's the end, and I do have a couple of references that you can look at. And I and Tiffany will take questions at this time. Thank you for listening. You can share your case studies too. Are you able to unmute yourselves? Oh, okay. It's already, you're able to unmute if you have a question. Okay, wow, no questions.
Yeah, I just got unmuted. This is Dr. Chodoraysky. I don't know if you can hear me.
Yes, we can
Yes.
hear you now.
Okay, thank you. Anyway, thank you, Dr. Musunori. This was really a very, I think, excellent presentation. I learned a lot. Some of it, I think, it is a reinforcer of things that I've been exposed to in the past. I think that, since Bridgeway, we've become an affiliate of Woods, and I think some of our prescribers may be involved with working with the intellectually developmentally disabled. I think one of the things that I see here is really crucial is that the way that and you obviously have explained that very clearly, how these individuals who have these disabilities, how they present themselves in a way that can be very, I think, misleading. If you are not really experienced in terms of dealing with this population, and how important it is to have the time and the ability to get basically collateral information from other sources and so forth. And I think, I'm thinking to myself, it's sort of like, it's very easy to jump to a certain action or a certain mode of treatment without having all the information necessary to ensure that you're on the right course. And even when you do that, like if you see with the examples here, you started with a prescriber of clonidine, then you went to basic Claritin, and then you finally realized what the problem was, that this was migraine. So there's a certain trial and error that basically you go through, which is, I guess to some extent, the your experience is almost unavoidable. But if you are not really that experienced, that trial and error can be a very long process almost. So the question is, how do we basically shorten it and so forth? And I think that's you obviously, I think if our prescribers are going to be involved with treating this population, they really need this presentation. I think that's really important to them because it primes them to really look at it a little bit differently. It's sort of like if you're a child psychiatrist, you're dealing with a 4 or 5-year-old. Okay, they're not going to be able to tell you, you know what I mean? They may be acting out, or they look like they're acting out, but really it could be a medical issue. Okay, if you're dealing with a teenager, they will act out. They will not tell you everything, but it's going to be more likely to be a social relationship thing. It's not going to be because they have a headache or because they have urinary tract infection. So I think those are the things that are really is important for the prescribers to keep in mind in terms of dealing with this population. And also, I think that collateral, I mean, it depends on the collateral information you're getting, but when it comes to the providers, I think it's also keep in mind that they themselves can come up with their own conclusions, which may not be accurate, and give you this information, and you end up running with it, whether you need to kind of think about it a little bit more. So anyway, those are the issues I see in terms of going ahead and working with this population. But thank you very much. I think it was really excellent and very informative.
Thank you, Dr. Sir. Those are all very valid points. And I think, Stephanie was in, we can discuss offline. We'll be doing more of the case consultation and training in future. One of the things as we develop, the Bridgeway, kind of like seeing more clients with autism and IDD, or any practice or any provider, at the outset, I think there should be a detailed intake assessment, and maybe some of these forms in the outpatient appointment when we are seeing them. It's so difficult to get or gather all the information that we need to make a decision or assess the individual accurately. In the Center for Behavioral Health, we always recommend that they do an intake assessment with the clinician first. And a lot of times if the child is going to be having a lot of behaviors, maybe with the parents virtually, gather information and then see the client, because they won't be able to explain what's going on. And it's really important to gather information from multiple people. If it is a child, from the school setting, if there is a clinical team involved working with the child, from them, even if it's an adult, it's a different situation. So the collateral information, as you mentioned, is really important. And also the coordination with the primary care physician. Anyone else?
Thank you. I have a for Ms. Tiffany. Hi. I enjoyed your presentation. Concerning my individual that we spoke about, you said some great things about incontinence and things that may work. Do you see any of that working in my individual, that he was doing well with using the toilet, but then he for some reason went back, digressed and everything, and I'm just really stuck and I'm really trying to work with the teachers, the school, and the staff here, to put them on a regular schedule. But what you were saying about the medications, is that something that might help?
Yeah,
Derek, before Tiffany answers, I was going to tell, when Tiffany mentioned one thing, I'm looking to see if Dr. O is on. With the constipation, there is always the risk that we go into is the overflow incontinence. And a lot of times that can look like they're, having feces everywhere. That's so difficult to address and understand. It's he went to the bathroom. The staff will be having some difficulty with really understanding, like, oh, he went to the bathroom. He's still, he's pooping everywhere, kind of thing. Jump in, Tiffany. I just want. Oh, okay. I was just going to say that overflow incontinence, we see that all the time when they are constipated.
Yeah, we definitely do. I also recently had a case like that this week. The staff is telling me, oh yeah, they just went to the restroom, but then on physical examination, their abdomen was extremely hard and firm. We did an x-ray and it showed like they were impacted. So you can still, staff may still tell you like, hey, they're going to the restroom, but on physical examination, it tells you otherwise that they're really impacted.
Go ahead, Tiff.
Yeah, and this is one of those situations where it's definitely the integrated management approach, because you can see we've got the integration not only with the medical team, right, where I know we just discussed this case last week, and I've been back and forth with Holly. I know we're exploring a GI evaluation, and she discussed some other medications she was going to look into for him. I think she was just kind of determined if she wanted to try something first before we go through GI. But also with the residential side and with the clinical side of working with him around those bowel habits, and having staff help him just to keep him on track so we don't lose the progress that he's made while we're working through all of this. So I think it's been definitely a complicated situation that's involved really everybody while we try to work through it. But I know we're gonna, Dr. Williams will still be talking about this, no doubt about that.
Yeah.
We figure it out.
One of the other things, Derek, we get into the picture is that, if there is like incontinence, he's getting a lot of attention as well. People, we are constantly after them, that I'm not denying the fact it can reinforce. There is a behavioral component as well that, we need to work on eventually. Some of these things can be reinforcing for the individual as well.
Thank you.
Anyone else? Okay, we are giving back 5 minutes of your time. Thank you all for joining.
All right,
Bye.
thank you.
Bye.
Bye-bye. Thank you.
Bye.
Yeah. I just got out of a meeting.